Hello, everyone. My name is Patricia Westmoreland, and I'm the president of the Colorado Psychiatric Society.
And my name is Vicente Liz. I'm the president-elect of the New York County Psychiatric Society. Thank you so much for joining this special edition of PsychSummit, a joint project between NYCPS and the Colorado Psychiatric Society.
We decided to put together this special forum for psychiatrists across the country to share our experience, challenges, and insights regarding COVID-19. During the crisis, I have been focused on writing editorials every week and coming up with a list of resources that we can send to our members. Vicente, what have you been doing?
Well, as you are all aware, here in New York State and New York City in particular, where I live, work, and practice, things have been particularly rough as we are the epicenter of the outbreak. As of today, I believe we have like 200,000 confirmed cases and up to close to 11,000 deaths. This is about a third of the total US cases and near half of their deaths. The pandemic has hit especially hard, and I think disproportionately, Hispanics and African Americans, highlighting the inequities of our healthcare system and our overall society as a whole. My hospital is located in the Bronx, which happens to be one of the actually the poorest congressional district in the nation. And we've witnessed firsthand the pandemic's toll in our community. I mean, we've managed close to 900 inpatient COVID cases, and we've discharged nearly 750 back to their homes and loved ones. And our ED has seen around 11,000 such cases. Due to my work at the hospital, I've been involved in a lot of the aspects of the efforts to deal with this unprecedented crisis. I mean, from coordinating the transition from live patients to telepsych in the outpatient clinics, and in CL psychiatry, we've also had to adapt at an unbelievable pace. Technology, I think, in general has helped and been an incredible tool, but it hasn't been, nor does it continue to be, kind of a seamless transition to it, I think. The lack of established processes to deal with all this, cameras, things like tablets and a reliable platform has been a challenge, not to mention navigating the technology divide between ourselves and our patients. And some instances, some of our patients don't even have a cell phone or even a reliable contact number into which to reach them. I think that from the medical psychiatric perspective, we've been as proactive as we can. We've shifted to more curbsiding of consults with primary teams, phone consults for our patients when and if they have phones available. I mean, since the hospital has included areas for patient care that up until like a week before, 2 weeks before, weren't even considered for acute or critical patient care. A lot of these places don't have phones. So here, telehealth and telepsychiatric has not been as helpful as much. Getting tablets to the patients by coordinating with, patient care technicians or nurses has been a challenge. And, we've been left to actually provide direct patient care to COVID-stricken patients throughout the hospital. I mean, talking to the doctors, to the teams, the nurses, the greeters, we've found that the experience that they've been living through and dealing with, they've withstand an incredible amount of stress, and they've been exposed to such loss, and just the volume of the loss, it has become a truly traumatic event. And it has started to show. We've been trying to provide wellness checks. So we actually go through the floors and we provide rounds. So a designated person goes every day for about half of the day with some volunteers from our psychology department. And they engage in a very impromptu manner. Residents, fellows, attendings, and nurses. We ask them about their experience dealing with whatever's going on that day, and that we're there to provide help, to provide them with a time, space, for them to share, to even, hear themselves speak out loud their thoughts, if just to vent. And we do this on all floors. Some are more receptive than others, and this changes day to day. But we've had very intense moments with one person, for example, starts sharing their thoughts, and all of a sudden the whole group becomes involved. So it's been a pretty powerful experience, and I think very useful for our colleagues. I mean, I think that, in the midst of all this death and chaos, the best people and the best of people have really shown, and everybody's working together, working tirelessly to just care for our patients.
Thank you. Wow, it's just absolutely unbelievable. Every time I read the news or hear about what you folk are going through, we're seeing a small fraction of that here in Colorado, and we're also trying to adapt with rapidity to the situation, moving to telehealth where we can, and even looking at how we can manage inpatient units better. There are some inpatient units in Colorado that have actually become designated COVID-19 positive patients, so that those patients can, at least receive psychiatric treatment in a setting that will hopefully not have them spreading the illness to other patients who do not have COVID-19. We're certainly reading a lot about how our fellow medical professionals are being affected. And together with the Colorado Medical Association, we're trying to take on as much of an advocacy role as possible to get all the physicians and healthcare workers in the state the equipment they need, and also to work on legislation that enables telephone health as much as televideo health. And also looking at ways to minimize liability for physicians who are practicing outside their scope of practice. But I believe there's a lot of work to be done. And in part one of a two-part editorial that I have written for the Colorado Psychiatric Society, we're really concerned that we're going to see a tsunami of mental illness that follows in the wake of COVID-19, not only for our patients who are vulnerable to begin with, but also for our fellow healthcare workers. And we are going to need to respond to that very quickly. So I believe that there'll be two parts of this event today. Firstly, we're going to hear about experiences and insights from New York psychiatrists working at the epicenter of the US outbreak. And you have so eloquently and beautifully started that conversation. Then we will break into self-selected discussion rooms. As you interact directly with your colleagues across the country, don't forget, we also want to hear your ideas, i.e. ideas from all over the country for future conversations, because we know that the COVID-19 crisis will have impacts on mental health for a long time to come.
So thank you for joining us for the start of this important conversation. We want to thank our supporters and co-sponsors for helping make this event possible. Now, let's hear from some of our New York City colleagues.
Hi, everyone. My name is Dr. Danielle Kushner. I am a forensic and correctional psychiatrist working at New York City's Correctional Health Services at Rikers Island. There has been a lot of concern about the development and spread of COVID-19 in the correctional system, especially here at Rikers Island, due to the close proximity of living quarters. Given the stress of the situation and its resulting potential to worsen psychiatric symptoms, it has been important to continue mental health and psychiatric services in the correctional system. In response, we have adapted and streamlined our services to minimize patient exposure while continuing to monitor and see patients. In addition, mental health services have continued to follow patients when they are being treated for COVID symptoms in COVID-designated housing. My main goal has been to support my patients and help them not feel abandoned during this crisis.
Hi, my name is Daniel Safin. I'm the program director of the psychiatry residency here at Mount Sinai Beth Israel in Lower Manhattan. The last 4 to 5 weeks have seen drastic changes in our psychiatry residency program, as we have half of our residents currently redeployed to internal medicine and the other half redeployed within psychiatry. Residents from PGY 1 through PGY 4 year are currently on internal medicine, and the traditional structure of our program and assignments based on PGY year is no longer in place within our roles here in psychiatry. This has required a lot of structural change for the program itself, as well as coming up with new and creative ways to do didactics, support programs for our residents. Our chair and our vice chair have been very helpful in advocating for support programs for our residents who've gone over to internal medicine, some of whom have been away from internal medicine for at least 3 years. These times have brought unique sets of challenges, and what we have tried to do as a residency program is keep our residents as informed as we can. We make them aware that during these timeframes, the information is ever changing and that there are needs that arise for us to make last-minute schedule changes, but really that transparency has been so helpful to our residents, at least in the feedback that we hear. We've been strong advocates for them around PPE, around supervision during these times. And our hope is really to continue to do this for as long as we need to make sure that we can restore the health to this community, not only on the physical front, but on the mental health front as well.
Hi, I'm Dr. Anna Kostakis. I'm a psychiatrist and the Director of Adult Ambulatory Psychiatry at North Wellsacre Hillside Hospital. I'm here to tell you about how we got our clinic ready for the COVID pandemic. So first and foremost, we moved to remote operations for our clinic day-to-day activities as quickly as possible for the safety of our staff and for our patients. We need to pull off the Band-Aid as quickly as possible to go remote, groups, individual, all of it in a snap.
Communicate, communicate, communicate. Use Zoom meetings frequently to keep people from feeling isolated. Find little ways to lift each other up and appreciate everyone who steps up. Prioritize self-care. Take time to connect with your patients and your team during this crisis. We will get through it together.
Hi, everyone. I'm Dr. Gabrielle Shapiro. I'm a doctor in East Harlem, and I work in both a mental health clinic and in a collaborative care, integrated care, primary care clinic in East Harlem. I want to just share my experience of probably in the very beginning of March, trying to move everyone to get ready to go virtual. There was a lot of resistance in the primary care clinic, which is still open. However, our mental health team did go to virtual about 2.5 weeks ago. And thankfully at my settlement house, Union Settlement, people listened, and we actually went virtual almost a month ago now, with very good success. I'm a child and adolescent psychiatrist, mostly work with Hispanic patients and immigrants. And it's been really wonderful to work with children in their homes, to be able to support parents. And we've had a very low no-show rate. So it's been a very positive experience. Also volunteering as a volunteer faculty for any emergent virtual visits for Sinai, and also signed up with New York Health and Hospital Corporation. And so it's been a great experience. There are a lot of challenges, and I unfortunately lost a very good friend of mine who's an ER doc in New York, Frank Gabrin. So I hope we're all being safe out there and protected. And if I can answer any questions about how we facilitated this, it's interesting. So we have Zoom, we have DoxyMe, we have FaceTime and WhatsApp as options. And to tell the truth, the majority of the immigrant patients are preferring WhatsApp because they all have it and it's easier for them to navigate. Anyway, be safe, everyone. Look forward to seeing everyone again live. Thank you.
My name is Dr. Jose Vito from New York City, the epicenter of the pandemic coronavirus. The personal risk, the unseen lethal enemy of COVID-19, the extreme physical and mental fatigue, inadequate resources, and unending accumulations of the dead. The absence of social support for this type of stressor is immense. Every time a patient dies, a piece of a provider dies too. This is often forgotten. Know that you are not alone. We feel your feels. Leaders of hospitals and everyone in the medical profession needs to communicate and needs to recognize that we also need support in this crisis. We need to reach out to debrief after dealing with particular stressful cases and issues. It does matter. So don't be afraid to seek help. Thank you.
Hi, I'm John Avery. I'm the Director of Addiction Psychiatry at New York Presbyterian Hospital and Weill Cornell Medical College. Here to talk about some of our responses to COVID-19, especially from the viewpoint of an addiction psychiatrist who also spends time on the consultation liaison service here. So one of the big changes, at least as it pertains to our patients with substance use disorders, is we've seen a lot less people presenting to the hospital with issues, especially with alcohol and opioid use disorder. Certainly we see some of the severe cases and overdoses, but the numbers have drastically declined. That being said, we've seen a lot of people engage with care who haven't previously, as we've really ramped up our telehealth and telepsychiatry platforms here. And so I think a lot of folks that were reluctant to engage with a psychiatrist have found engaging with us in the comfort of their own home to be something that's more palatable and doable. How these numbers will shake out eventually in terms of people receiving care or not, I think is to be determined, but those are some of the early trends. I will say for all of our private patients here at the hospital in the setting of COVID-19, we're doing everything by telehealth and telepsychiatry. The other big change in my role as a psychiatrist here at a big medical center is that a lot of my time now is spent as part of a team of psychiatrists and psychologists supporting providers who are taking care of the COVID-19 patients, those on the front lines. And that includes doing individual work, group work, and sort of check-ins during the day for a number of staff, from nurses to security workers to hospital transport, to certainly the doctors and other clinicians on the front line taking care of folks with COVID-19. Some of this is done in person, but a lot of it is done via Zoom and telehealth platforms as well. You know, and the stories are many and varied, and certainly there's been, you know, a lot of sadness and death, and at the same time, a lot of people rallying together and to support each other and to tackle this difficult time of being a provider and certainly a person battling COVID-19. I hope that gave a little insight into what's going on here, and I hope everyone's staying safe. Thanks.
Hi there. I hope you've been enjoying the Psych Summit. My name is Alan Rodriguez Penny, and I'm a public psychiatry fellow at Columbia University, and I'm also a part-time psychiatrist at Janian Medical Care, which is a nonprofit organization that works with people who are formerly or currently homeless. So I was asked to film a small piece or a small clip of my experience as a fellow during these times. And so one of the most challenging things for me is not being able to hang out with people face to face anymore. And so one of the things I do keep in mind, though, is that social distancing does not equal social isolation. And so I do take the time to connect with my friends and family through video chat. And I do live with my partner who works as an ER doc. And so through her, I've been able to get a sense of how the whole situation has transformed the emergency room and the hospitals around us. I mean, I live in New York and Brooklyn, so one of the epicenters of that's going on right now. And I really think we're all doing the best that we can, whether that's taking our time to volunteer or even just being a source of support and reassurance to our families, friends, and colleagues. This is my dog, Sensei. He's a golden retriever. He's kind of sleepy right now, but he's totally oblivious to the whole pandemic, and he's really enjoying having me around all the time. So that's one of the plus sides for him. Well, I hope you enjoy this and enjoy the rest of the conference. Take care of yourselves.
Hello, I'm David Rowan. I'm the president of the New York County Psychiatric Society and chair of psychiatry at Lenox Hill Hospital in Manhattan. And I'm here today with Bruce Schwartz, who's the APA president and professor, deputy chair, and clinical director of psychiatry and behavioral services at Montefiore Hospital. Thanks for joining me, Bruce.
Good to be
I
here.
just want to check in and see how your family is doing and if everyone's well.
We're all doing well. I've got two children who are very much involved in the healthcare system. One, a son who's an emergency medicine resident at Northwell. So he's in the middle of it at LIJ.
Yeah.
And but he's so far so good. And then I've got a daughter who's a nurse practitioner in psychiatry at Mount Sinai. who is also very much, kind of in the middle of it. So, but they're
Scary
all
times for a
goodness.
parent, I would think.
Yeah, it is nerve-wracking.
So I know that the audience is going to be very interested in what you have to say, in part because of your great experience in psychiatry, but also because you are right in the thick of this problem right now here in New York City. So let me start by asking you about Montefiore Hospital. How has the hospital been managing the pandemic in the Bronx, and what has been the role of your psychiatry program?
So Montefiore has been completely, unfortunately, in the bullseye of the pandemic. The Bronx has very large health disparities with lots of obesity and diabetes and hypertension. It's a minority population, Hispanic and Black, and it has hit very, very hard in the Bronx. So the hospital, has been swamped with patients. It's beginning now we're getting a little bit of breathing room, but it's been, all COVID, 24/7. There was a period of time when it didn't look or feel as if it was ever going to end. They took over every space in the hospital that they could possibly take over to put patients, in terms of expanding, essentially building ICU beds in conference rooms and meeting spaces, hallways, everywhere. So it has been a really very, very trying time for the hospital. And in terms of psychiatry, what has happened to us is many of our, especially residents, have been redeployed. I do have to say the first psychiatry staff to have been redeployed were our nurse practitioners. They were the first ones yanked from various programs, and then came, residents and social workers, that it was really necessary to kind of meet the crisis needs of what was going on the units. In terms of the role...
Tell me about any issues or concerns that you have about the reassignment of psychiatrists and your staff in areas outside of their comfort zone.
Yeah, well, it's, fortunately, we started with with the PGY 1s and 2s because they were really closest, to their medicine experience. What has been done well by the hospital is that nobody was sort of thrown into the thick of it without adequate, support. So that the residents, the feedback that we've gotten from the residents is that they very much feel supported, that they don't feel that they're operating outside of their ability to sort of function. I think the hard part for them has been, it's a schedule of 7 days on, 7 days off, and even those 7 days off, you're subject, potentially to being, called in, because many healthcare staff have been getting ill. Everyone, social workers, nurses, physicians, have been getting ill. But the residents have said they've really felt supported, and that there was enough, expertise, medical backup, so that they could function well in terms of what they were being asked to do.
How has it affected your attending psychiatrists?
So the attendings clearly have had to begin to fill in, for the residents. That's previously services that had some residents or that residents were doing on call. The attendings, have, been filling in and doing the work, without the benefit, of the residents. Much of the work is being done in terms of telepsychiatry, however. So that for our CL service, most of the consults are done using telepsychiatry. Even on the inpatient unit, we would rotate staff so that teams would be off for a week, and one team would be managing the unit, and then, when it was their time to be off, the other team came in. So you didn't expose everyone at the same time to becoming infected.
Now, particularly in CL, I know it's been a great challenge to implement telepsychiatry. Can you tell us anything about how you've tried to overcome some of those difficulties?
Well, it's a challenge. People have been using iPhones and iPads to do the consultations. So that's, we sort of had to learn how to do telepsychiatry on the fly.
Mm-hmm.
Fortunately, it's worked. People feel that they can do a good job, with telepsychiatry. At the same time, the volume of consults dropped, as did ER visits and even patients, coming into the inpatient unit, because the entire hospital essentially became a COVID hospital. So that the psychiatric demands from these patients, weren't that great. Where the demand was, however, was helping the medical staff, nurses, social work, residents, physicians, in terms of the emotional stresses, that the staff have been experiencing.
So tell me how you've been able to help them.
Well, we've done a few things. One is there are, call-in lines that a staff member can, pick up the phone and call someone to talk with them. There's a caregiver support center, which is staffed, where staff can go and, meet with a clinician. We've also expedited referrals so that for anyone, who felt they needed kind of more intensive treatment, they could quickly get, paired up, with a clinician. That's been another thing. And then there's been outreach so that every single staff member at Montefiore, and there's 6, 7, 8,000 staff members, the list has been divided up among all the psychiatry staff, and they kind of do some outreach to everyone so that all the staff feel as if there is someone who they can contact, they have a name, they have an ability to sort of reach out, if they feel in particular distress.
Now, there's a perception, I think, that in the early stages of crises like this, whether you're talking about the community or even with healthcare providers, you may not see that many people reaching out for mental health services. But then as we get into the later stages, it becomes a more important part of the equation. I wonder if you agree with that, and if so, what you anticipate we're going to need to be able to do to take care of all these people as we move into the later stages.
I think that's very true. That in the beginning, people are just focused on not drowning, and that's all they're concerned about. However, this epidemic has been sufficiently ongoing and devastating. Residents who I treat, it's nightmarish. They go on their service, and in the course of a 12-hour or 13-hour shift, they have 4, 5, 6 codes on their units. So the lethality of this virus, especially, to a population with many health disparities, has been particularly disastrous. And the experience of people dying alone in the hospital, family members, being unable to visit, it's hard for that. It's impossible for that not to impact caregivers because it's so outside, the norm. So there has been some morbidity among the staff in terms of stress. We do know, however, that after this passes, probably about a third of the individuals who have been under such chronic stress, are going to develop, more significant problems. So there has been essentially a problem that's already developed, and subsequently there's going to be kind of even more problems that develop.
Mm-hmm. Okay. Now, moving to outpatient services, because I think maybe that's been a little bit lost in all this. What do you see as the role of outpatient psychiatry in this crisis, and how have you been able to maintain access for patients?
Right. Well, fortunately, in New York State liberalized our ability to use the telephone to stay in contact with patients and to be adequately compensated for those telephonic contacts. Because for many of the patients, they just either don't have sort of the equipment or adequate internet access in terms of, being able to, be contacted using telepsychiatry. So our staff have been really very busy maintaining contact, with all their patients. I have to say the no-show rate is way down because when you're calling people at home, they're there. You don't have to worry about them missing their appointments. So on one level, it's actually been quite efficient for our outpatient providers, but the patients have continued to be treated, despite the epidemic, and we have been doing intakes as well, so that we still get, calls and contacts from patients or patients being referred in by their primary care physician for treatment. And we've continued to do intakes, some live, others being, done telephonically.
I know here at Lenox, the Office of Mental Health, I'm sure you're aware, has really encouraged all the outpatient programs to maintain the intakes to prevent patients from having to go to the emergency room or get admitted into the inpatient units if that's possible to prevent.
Yeah, the last thing we need is for patients who are in established care and doing well to decompensate and end up coming into the emergency department. So that's, I think, a really very strong rationale for maintaining, outpatient care. There has been a challenge, in part because we had a lot of patients on long-acting injectables, and as many of our nurses were getting pulled, the nurse practitioners were being pulled, the sheer numbers of patients who required injections was kind of stressing the system. So I think the one thing which I'm not happy about is that some patients ended up being transitioned, to oral medication when previously they were on a long-acting injectable. But all of those decisions were sort of carefully reviewed, and patients where it was clear that they needed to remain on the long-acting injectables, continue to receive them.
Right.
But when so many staff are being, reassigned, to other areas, and all our staff, clearly were subject, to being reassigned, it's a challenge.
So in general, what lessons would you say you've learned that other states could benefit from hearing as they begin to deal with this crisis?
Well, there's a few things. In terms of the crisis in New York, the thing that really most disturbed me was some of the advice coming out, whether it was from the CDC or from our own epidemiologists, that staff didn't need to wear masks, or that patients, didn't need to wear masks. And that was, I think, maybe they believed it, but I think it was more a function of the fact that that personal protective equipment was just not available. And the hospital, had to really carefully, sort of guard its supplies. So one is clearly have, as much PPE as you can possibly have. We had problems on our inpatient units where we had cases, and it's a communal setting. And, when you admit a patient to a medical unit, they're in their own room. They have their own bathroom. They're not wandering, the hallways. They're not taking, communal meals. So on a psychiatric unit, which is really a communal setting, almost potentially, like a nursing home, except the patients, are very ambulatory. It's very important to make sure that you take every precaution you possibly could. And there were some concerns as to whether patients would wear masks. That really turned out not to be much of an issue. Most of the patients, were willing to wear them, and the staff, certainly after we started, having cases, the staff were told to wear masks, but we also masked our patients. testing was not readily available. So for asymptomatic patients who were being admitted to the inpatient unit, I think it's important that to whatever degree is possible to take patients and screen them with testing to see whether they have, the COVID virus. That's something I would implement, because once you get a patient with COVID admitted to an inpatient unit, that patient's going to infect many, many, many more patients. So prevention is very important, and screening patients for the virus, not just asking them questions, but testing, and if possible, doing rapid testing is something I would advise people in other areas of the country in terms of protecting, their population. Clearly, having adequate PPE for patients and for staff, I think is sort of very important. I sort of morbid joke. I say, we've gotten to a position where we were constantly developing new contingency plans for our contingency plans. No matter how thoughtful we were in terms of preparing, for these things, it always, the next day, the plan clearly needed updating. So we have, I think it's important that, staff are familiar with other services because they may need to go from CL to inpatient. It's critical that also a lot of work with the staff in terms of supporting them and helping them appreciate, what was going on, and giving them as much, support as possible so that they become familiar, with the services.
Well, you're making the point that it's very hard to predict what's going to happen with this crisis from one day to the next, let alone 1 week or 1 month. So I'm not going to ask you to make any predictions, but I would like to ask you what changes you hope would come out of this crisis with regards to mental health services and practices.
I think the most important thing that will emerge from this is that telepsychiatry will become firmly established, as a treatment option. Again, we had plans to implement it throughout our system, and the epidemic kind of overtook us, and we learned really on the fly. But I think telepsychiatry is not going to go away after this. It's a very efficient way of providing care. It's very effective. It works. And I think that's something which is not going to, change. And I think some of the waivers that the federal government gave in terms of some of the geographic waivers, there were rules in, New York State about, where could you do telepsychiatry from where to where. I think telepsychiatry is sort of here to stay. And I think that's a very positive, change. I think the other thing that will emerge from this crisis is the recognition of how important psychological services are to staff who are dealing, with these crises, as well as to individuals, patients, who are losing family members and friends or getting ill. There's a whole population who are going to be psychologically affected, by this. The other element is we made use of everyone, so that everyone from our social workers, nurse practitioners, psychologists, psychiatrists, everyone pitched in, that everyone had a role to play. We very much we could not have met even a fraction of the psychological needs of the staff at Montefiore, if not for the social work and the psychology staff in terms of their being able to do counseling.
Great. Okay, Bruce, thanks so much for your time. I'm really sorry that we're not going to be able to spend time together in Philadelphia later this month, but I look forward to seeing and talking to you in the near future. Take care. Be well.
You too. Thank you. Stay well.
Okay.
Bye.
Bye.
I hope you're finding value so far in this virtual event. So now it's time to transition to the next part, which will take a different format to dive deeper into the conversation. So right now in the attendee chat, we are dropping links to multiple Zoom webinar rooms arranged by topic. So each room will have facilitators live on camera. It will also have a continued attendee chat where you can share questions and comments to fellow attendees as you are. But you'll now also have the option to share directly on video. You'll see a raise hand button, which you can use if you have something you want to share with the rest of the group. Clicking raise hand indicates that you want to be brought on screen temporarily as a panelist to share with the rest of the group. If you'd like to switch between rooms, you can come back here and click to another room. We'll see you in there.